Well, why don't we go ahead and get started with the Q&A session. Hi, everyone. Why don't we go ahead and get started with the Q&A session. So I wanted to explain the genesis of this Q&A session. All of the questions that we're going to be going over tonight were actually submitted by the patients and advocates. We had about 25 people who submitted questions. Some people submitted one question. Some people submitted 3 pages of questions. And I and Rachel Jankowitz here went through all of the questions. A lot of times we actually found themes to the questions that people were asking over and over. And so based on that, we came up with a group of about 10 questions that we thought represented the questions that the advocates thought were the most critical. And so you can see the esteemed panel that we have here, a mix of clinicians, clinician scientists, and scientists. And so we're kind of just going to go through the questions one by one, and I'll kind of pick someone to start, but I would love to have everybody's input if you have something to say that's related to the topic. So the first question is related to early detection of primary invasive lobular cancer. And the question is, some patients were concerned that their lobular cancer was picked up late. And so I thought we could start with Wendy Berg, who's a radiologist. Are there better methods for early detection for primary invasive lobular cancer?
Right, so a lot of these issues I did touch on this morning, I guess it was. MRI is certainly the most sensitive test that we have for screening for breast cancer, including invasive lobular cancer, but it often at this point is not covered by insurance unless the patient meets high-risk criteria, and unfortunately a prior history of cancer does not currently make that list. I know that the American Cancer Society is currently revisiting their guidelines for supplemental screening in all groups of women at somewhat increased risk, including women with dense breasts. And we were hoping to see that guideline come out this year. I think it's being delayed, and it probably won't come out until next year. But hopefully they will at least address this. We know MRI has been studied in women with personal history of cancer, and it certainly increases the detection as it does in every group, including completely average risk women with normal mammogram and ultrasound. So it is something to consider if you can get coverage. And then we also talked about fast MRI as an alternative, but that's not widely available right now. And that would be an out-of-pocket cost of anywhere from $300 at a few facilities that are offering it. There's one in Michigan, David Straley, that's doing that as well. But it's not widely available right now. Short of that, certainly much more widely available is tomosynthesis, which is far better than a routine mammogram, especially for lobular cancer, because we do see the distortion so much better. It's not perfect, and we know already from the results from Italy and also from our own study that we still see more cancers when we add ultrasound to tomosynthesis, but we need more information on that for that to change policy. That said, if you can get an ultrasound and a tomosynthesis, you're going to do better than if you had a regular mammogram. But none of these tests are perfect. So that's kind of where it is. And ultrasound is certainly best and most widely suggested in women who have denser breast tissue, where we know that more cancers are hidden. And tomosynthesis is less helpful in detecting more cancers in extremely dense breasts. So it has the benefit is seen really only in the heterogeneously dense, scattered fibroglandular density and fatty breasts. And at this time, women are only notified of their breast density in 28 states. So you're not necessarily even going to know your breast density, but it is in your mammogram report, and you can ask your doctor. So that's kind of where we are.
And what about imaging techniques that look at circulating biomarkers?
Well, I mean, PET has been used, for example, to look at metabolic activity. There's a dedicated breast PET device, but it is less sensitive than MRI. There really aren't a lot of other approaches in that respect that have been widely studied. The molecular breast imaging, I talked about sestamibi, and that is not a biomarker per se, but it does show cancers that we don't see sometimes with ultrasound or with mammography. but it requires radiation exposure. Contrast-enhanced mammography is another option, but again, it requires injection of contrast and isn't widely available for screening right now. So they're really, I mean, those are the sort of in the works, but not necessarily widely available, not necessarily what you would choose to have at this point.
Do the basic scientists have any additional thoughts about things on the horizon from the standpoint of imaging and research?
Yeah, so there's actually quite a lot now ongoing in this idea of this liquid biopsies for looking for early detection. So UPCI just received 2 awards from the Early Detection Research Network to look, not in breast, unfortunately, but one in lung and one in colorectal to look for mutations in, take the DNA that's circulating from your blood, see if you find mutations, and if you do, maybe that's an indicator of an early diagnosis of cancer. I'm not sure what's going on in breast. There is a company that actually already offers this, Pathway Genomics. They have a test called Cancer Intercept, which basically they sequence blood, and if they find mutations, then you have to go for extra screening. So there's a lot, I think a lot of people have hope that this might be and more than likely I think it will be used as a supplement to mammography in breast cancer as an example. But this is very early research, there's a lot going on.
The little bit that I know about what's going on in that regard is very low specificity, so a lot of false positives, and then that causes, of course, a lot of anxiety because imaging at present is not, cellular based. We need at least kind of 5 millimeter and closer to a centimeter size tumor, which is, 1 million tumor cells before we can really identify it reliably. So there's a lot of concern about that approach at present with breast cancer because of the high false positive rates.
I think there is some excitement there with estrogen receptor mutations, which are going to be a bit more positive, but then the issue is you're already talking about a resistant setting, so it comes down to the issue of once you find it, what do you do about it? And we don't know the answer to that question yet, so the biopsies make it to the point where we can find it circulating, but.
Any other thoughts about imaging from the panel before we move on to the next question? So the next question that was submitted by the advocates was related to what we call local therapy of invasive lobular cancer, which usually means surgery and radiation. So the first question in that group was, should patients with ILC alter their local treatment to reduce the risk of local regional recurrence? Dr. Arndt, do you want to start answering that question?
So I think that the principles that we apply for oncologic resection of breast tumors apply to ductal carcinoma in situ, invasive ductal, or invasive lobular, which is that if we can oncologically remove the tumor with a margin of normal healthy tissue around it and apply whole breast radiation as a follow-up, we don't have any evidence that there are higher rates of in-breast recurrence for lobular than for ductal carcinoma. I think the real challenge with lobular carcinoma is accurately mapping it and knowing the extent of disease in the breast for surgical planning. And it is more of a challenge to perform breast-conserving therapy because these tumors tend to be multifocal and more diffuse at the time of diagnosis. But lobular per se is not a reason to go to mastectomy.
Because ILC might have an increased propensity, though, to having bilateral disease, is there anything surgically that's done because of that?
So people in this room probably know that historically when lobular cancers were maybe less well understood than they are now, bilateral mastectomies was the traditional management. I guess I know that's what the doctor books say, that it's more likely to be bilateral, but when you look at good SEER longitudinal studies of rates of contralateral breast cancer, they're actually relatively low. They're about 5%. And even if you hypothesize that all contralateral breast cancer is in the lobular population, the rates are still relatively low. And since this is a group of tumors that is almost uniformly hormone receptor positive, patients are now on anti-estrogen therapy for a minimum of 5 years if tolerated, if not longer, which almost certainly reduces the risk of contralateral breast cancer. So I think screening the contralateral breast at the time of a lobular cancer diagnosis with breast MRI, which we're getting for extent of disease in the affected breast, if that MRI is otherwise negative, I would not advocate a contralateral prophylactic mastectomy simply because of lobular histology. If there were family history to suggest a hereditary pattern of cancer, we've heard a lot about CDH1 mutations, BRCA2 mutations. Absolutely, genetic testing would be undertaken to guide recommendations for management of the contralateral breast.
Dr. Barry Wall, who's in radiation oncology, what are your thoughts about the effectiveness of radiation in invasive lobular cancer compared to other subtypes of breast cancer?
So at this point, as Dr. Arndt mentioned, there is nothing to suggest that lobular have any higher recurrence rate after adequate local treatment, whether it is lumpectomy or radiation or mastectomy and radiation. So they behave similarly in terms of overall outcome for local regional relapse. As long as you get negative margin and you do radiation therapy, the risk of ipsilateral breast tumor recurrence is 5% or lower. And similarly, after mastectomy, if they meet the indication, then the efficacy of treatment and the benefit is similar. The only difference is because of the spread pattern and the way it spread, most of us would be reluctant to offer partial breast radiation therapy for lobular, which is an emerging modality where you treat part of the breast. And most of the data in that setting is for ductal cancer, not for lobular cancer. So most of the treatment with partial breast studies avoid treating lobular cancer for that reason. But otherwise, for standard whole breast radiation or post-mastectomy radiation, the outcome and recurrence look very similar to ductal cancer. And indication and need is very similar.
Are there any reasons why you'd be more likely or less likely to give post-mastectomy radiation to a patient with invasive lobular cancer?
Not at this point. I mean, the indication is more or less similar based on node positivity, tumor size, and margin status. So they're more or less similar.
Any other thoughts on that from the panel?
So I just feel that in general, we learned from breast cancer in general, and this applies to lobular, that doing more surgery, mastectomies, or more nodal evaluation doesn't translate into improvements in overall survival. I think that we're improving the ways we treat patients from a systemic standpoint, but I don't think that doing more surgery. We don't have any data for lobular, and neither for other types of breast cancer, apart from the hereditary breast cancers, that doing more surgery general recommendation. And it's very unfortunate to see that we have a very increasing rates of mastectomy in the country.
So the first question about imaging, we asked specifically about screening, thinking about a population of patients who have no diagnosis. But the follow-up question from the advocates and patients related to imaging was, after a patient has their definitive surgery and radiation, their local therapy, what would be the best imaging and surveillance after the initial therapy?
And again, it's the same issues, the same sensitivity issues, and the same guidelines, unfortunately. We don't have currently a guideline that says you should get an MRI in that setting, although there is a suggestion from the NCCN that if the original tumor was not seen on mammography, that's relatively something where you would consider doing an MRI. And costs are certainly a factor for MRI. But it's the same issues. If you have dense breasts and have that history, adding ultrasound may help, but it's all the same issues as screening. Fundamentally, there's no difference in policy right now.
Should patients be screened more often?
It's still, that's been looked at to consider doing every 6-month mammography in women who have a personal history of breast cancer, and there's maybe a very, very slight benefit in a study that was done at UCSF, but other than that, there really isn't much, and it's certainly not the standard to do more than annual mammography at this point.
Any other thoughts about local therapy? So now we're going to move on to systemic therapy, meaning the treatments which are given to treat the whole entire body. And so I'm going to focus on Dr. Jankowitz and Dr. Metzger for this. Is there enough information now to change the way we approach endocrine therapy for invasive lobular cancer?
I can start maybe. So as you could see from the presentations this morning, we had data from retrospective studies that have looked into patients that had a diagnosis of lobular compared to ductal, and trying to understand what was the benefit of endocrine therapy. I was involved in one of these studies, and the reason we did these studies is because this is a disease that benefits so much from endocrine therapy that when I proposed this study, I thought maybe giving tamoxifen or AI, they're going to be equally effective because this is a subset of breast cancer that benefits so much from endocrine therapy. And these are medications that have different side effect profiles, so I thought that this information would be interesting. And when we run the analysis, we're very surprised to see the results that the subset of women diagnosed with lobular carcinoma and treated with tamoxifen, they had a worse outcome. So we're not very happy in seeing these results because we're not expecting, so we moved along and did a second analysis in the same study using a different set of population that was not included, another 4,000 women, and we saw the same trend. Later, a year later, we had an analysis from the Austrian group, and we saw the presentation from Dr. Knauer this morning from Switzerland that showed a similar trend, saying that patients can do slightly better when treated with an aromatase inhibitor when compared with tamoxifen. So if you ask me if this is the standard, the correct answer is no. We have suggestions from the literature, but here we have to make a pause and think what we are comparing. We're comparing tamoxifen to aromatase inhibitors. So aromatase inhibitors are drugs that are approved for breast cancer in general. And overall, for all breast cancer women in the postmenopausal setting, the aromatase inhibitors are slightly better in general. So it's not unreasonable to consider for a patient that had a diagnosis of lobular carcinoma to treat her with an aromatase inhibitor, because this is what we do for all cases. But as I said before, this is a group of medications that have specific side effects, and for some patients, this is just not tolerable. So, and it's not unreasonable for those that are having side effects to do a few years of an aromatase inhibitor and switch to tamoxifen, or either start with tamoxifen and do a few years of aromatase inhibitors. So we have multiple options, and the literature is just not perfect.
Yeah, I'd have to agree. What's really given me pause is when premenopausal patients start asking, when they see this data, should I actually go on ovarian suppression in order to avoid tamoxifen because I have a diagnosis of lobular breast cancer? And that's if we would not otherwise be recommending it to that patient based on their risk profile or their age or whatever we normally would have recommended ovarian suppression for, I really hesitate to tell that woman, yes, go on 5 years of ovarian suppression just to avoid tamoxifen. I don't think we're there yet. I find it confusing how the ABCSG8 analysis showed the majority of the benefit to the AI over tamoxifen in the luminal B cases. That wasn't really what we saw in Big 198. So I think we have more work to do to try to figure out which patients might have tamoxifen resistance and why. And I still think that a lot of patients do incredibly well on tamoxifen, and so I think you have to take quality of life into account and the morbidity of ovarian suppression, if we wouldn't have otherwise recommended it, is high. So I think we have more work to do to really answer that question.
I fully agree. This is a question that sometimes bothers us. We don't have a clear answer. And when we add ovarian suppression to a patient that has a diagnosis of a lobular carcinoma and she's in the premenopause, we are really impacting on the quality of life. We're making this patient from day 1 premenopause, day 2 postmenopause, with all the symptoms that come along. So this is not an easy decision. So try to individualize. If a patient had a higher risk of recurrence at baseline, sometimes we consider, we discuss with patients a lot. We explain our limitations in terms of the data, but there is no clear answer. I've been in touch with the groups that have conducted 2 of the clinical trials that are evaluating the benefit of ovarian suppression. These trials are called SOFT and TEXT, and we're just waiting the data to be more mature, so we have a longer follow-up for these patients to do the comparison of the lobular versus ductal in the premenopausal setting when treated with ovarian suppression.
So as we've sort of gone along here, we first spoke about screening of a healthy patient who was then diagnosed with a lobular cancer. Then we talked a little bit about local therapy. Then we talked about systemic therapy. But sometimes that order is different. Sometimes the systemic therapy comes before the surgery and radiation. Is there any evidence to support giving the systemic therapy prior to doing surgery and radiation?
Well, I think that it's been well established that neoadjuvant endocrine therapy works well for many women with lobular cancer. So I think that it takes longer. You know, often we're seeing more and more that up to 6 months of preoperative therapy is necessary to achieve the downstaging result that we want. But I certainly wouldn't have any hesitation to do preoperative endocrine therapy. I think preoperative chemotherapy for lobular cancer has been described to be less effective comparably to ductal patients. So that's an area of disappointment, I think. I don't know if you
I think that I fully agree with you, and I think that there might be advantages in doing treatment before surgery for lobular carcinoma that we still don't know and we still haven't realized. So what happens with lobular carcinoma is that we have re-excision rates after a primary surgery due to positive margins that range from 20 to 40%, depending on the series. So a patient has a diagnosis going to surgery. At the final pathology specimen, the margins had still tumor, and the surgeon had to go back and do an additional surgery. When you give any treatment before surgery, the major advantage and the way neoadjuvant therapy was created, it's just to shrink the tumor. So there's a potential here that if you give a treatment before surgery, that we believe that's going to be equally effective if given before or after, there might be a potential in reducing the rates of re-excision at the time that the patient goes into surgery.
Dr. Arndt, do you have any experience giving patients neoadjuvant therapy for lobular cancer specifically?
I do, and surgeons will use this approach, but I think that realistically, the success rate of downstaging lobular carcinomas is not as high as it is for ductal carcinomas, perhaps because of the growth pattern. Dr. Berg stepped away, but I think it's a real challenge also to re-image these patients after they've been on neoadjuvant aromatase inhibitor or tamoxifen therapy, because sometimes even on their baseline MRI, the tumor does not demonstrate a lot of enhancement, particularly if it's a low proliferative rate tumor, and then judging how much response they've had post-neoadjuvant therapy and using that information to translate into how much tissue you have to remove is a real challenge. So I do agree that anything we can do to reduce the need for a second surgery is absolutely a goal, but I think it's a real challenge with lobular tumors.
Dr. Berry-Wall, if somebody receives neoadjuvant therapy, does that change the radiation plan?
At this point, it doesn't. It depends on what kind of operation they have. If they have lumpectomy done, then the volume or dose of radiation is more or less same. It doesn't change the radiation plan. If they have mastectomy, then the indication need is based on what it was before and what it is after.
Can I just make one more comment about neoadjuvant therapy? Another indication that we're using frequently now for neoadjuvant therapy is to downstage disease in the axilla. And there are certain tumor phenotypes where we can expect a very high success rate of downstaging axillary disease and maybe eliminating the need for axillary node dissection. But in lobular cancers, the likelihood of a complete pathologic response is really very low, probably less than 5%. It's unlikely that we will be able to convert a patient who is node positive at presentation to less than an axillary node dissection.
So following up on the concept of complete pathologic response, there's some literature that suggests that if a patient does have a complete pathologic response, that their long-term survival might be better. So the question that was posed by the advocates and survivors was, what is the significance of a partial response in invasive lobular cancer related to recurrence and survival?
Well, this is a very good question. We know that for all subtypes, once a patient achieves a pathologically complete response, they do better in terms of outcome. For estrogen receptor positive and for lobular in general, this is not so clear because we give a few months of treatment before surgery, but most of the treatment, which is 5 years of endocrine therapy, is given after surgery. So it's very difficult to try to interpret what you can get in terms of benefit after a very short exposure and try to predict what's going to happen in terms of outcome. So the relationship between very good response after neoadjuvant therapy and outcome is much clearer for HER2 positive and triple negative than sets of estrogen receptor positive, such as lobular carcinoma. The other piece that's very important when we try to interpret how much of a response was achieved when a neoadjuvant treatment was given for estrogen receptor positive disease is the duration of the neoadjuvant therapy. We know that if we give neoadjuvant therapy for 4 months, we have a pathological complete response of 4%. This go up to 17% if this treatment is given for a year. So the duration is very important. It's just the way we interpret. So I think that the general message is not to try to interpret too much a pathology result after a short exposure to endocrine therapy before surgery.
Anybody have any other thoughts on that?
Yeah, I would agree. I mean, there's such a low percentage of strongly hormone receptor positive patients achieving a pass CR to begin with, that it's hard to then subset and say, well, what about lobular within that small percentage? But what we do know is that with serial breast biopsies, if patients have a good response to preoperative therapy, if their Ki-67 goes down on therapy, that is a good prognostic sign that the therapy is effective. So that might be a more meaningful thing to look at than the actual pass CR rate for hormone receptor positive disease.
So it sounds like what you're talking about there are biomarkers to predict response or recurrence. Are there other biomarkers that are used for that purpose? And if not, are there any on the horizon from a research standpoint?
The only thing I guess we could add is that there are trials ongoing, and maybe Dr. Jankowitz can comment on this. That in that neoadjuvant, in that window trial, we are not only looking at Ki-67, but we are looking at biomarkers we find in cell lines in the lab, and then look, okay, how do they change pre, post?
Yeah, I mean, that's the entire focus of our trial, is to try to, and other ongoing studies, to try to study tumor biomarkers before and after exposure to endocrine therapy, even on a more detailed basis than simple immunohistochemistry markers, but sequencing, like we've heard about all day today. But right now, what we currently have clinically available is the change in Ki-67 on therapy. What's on the horizon, I think, will be, for long-term outcome, might be more circulating biomarkers, circulating tumor cells perhaps, and circulating tumor DNA. That's of great interest to follow after early therapy for breast cancer. But again, that's another challenging area to interpret, when to follow them and which patients, and how, whether you need that or a tumor biopsy of a metastatic site, or you could simply follow these circulating biomarkers. So these are sort of the strategies for the future, to follow our patients and survey for recurrent disease, and can they be actionable and direct therapeutic strategies. I mean, that's what we're all hoping for, not just for lobular, but for all breast cancer.
One of the tools that medical oncologists use in general with breast cancer to determine what additional treatments might be needed after surgery are gene assays such as Oncotype and Mammaprint. Are those used in the treatment of lobular cancer?
This is a great question, and lobular being an estrogen receptor positive disease, the assay could potentially be used, and it has been used quite a lot in the country. So we have the data from the company that runs the assay that gives us the prediction, the information about chemotherapy, yes or no, which is the oncotype. So the company has data for over 30,000 lobular patients, but it was surprising to see that the results from the company, so these are just results from the test without follow-up of these patients and no real details, but they couldn't identify the high-risk subset based on the classifiers they have with the oncotype, the low, intermediate, and high scores. The proportion of lobular patients that had a high score on the oncotype was just 3.6%. And this is in somehow does not match well with other genomic results that we have from a retrospective series where the rate of high-grade disease using different methods was slightly higher. Not very high, but in the range of 10 to 15%. When we look across all series that have just histologic grade, which is the classical measure of proliferation that comes out of a pathology report, we see that about 10 to 15% of lobular patients, they are classified as histologic grade 3. So one debates what's the real utility of oncotype if we're not getting the high-grade oncotype result out of a test, but one could also say that the oncotype gives you a score which goes, and you can try to interpret. So if you have an intermediate score, it can be low intermediate, it can be high intermediate. So I feel that in somehow it does have some utility, but it also has some limitations that we still don't.
The question was related to tests that can be used to determine whether a patient will benefit from chemotherapy beyond the benefit they would get from endocrine therapy. Tests like that include oncotype and mammoprint. Any other thoughts about that one?
Yeah, that's a good point, but if we come from a point and when we say that we should not offer chemotherapy for all lobular carcinomas, my concern is that we might be missing patients that have a high-grade estrogen receptor positive disease and could benefit from adjuvant chemotherapy. So I don't think that we are ready to make this decision to say that we should not give chemotherapy based on the data from the oncotype or just give chemotherapy for just this 2% of the patients, because I feel that there might be a little bit more than 2% of lobulars that are that have a higher grade. And again, this is based on histologic grade. I'm going to present tomorrow data that I have from a series with 200 patients from my period in Brussels, where we found 10 to 15% of lobulars having a very high genomic grade and with prognostic implications. And so these are patients that might benefit from chemotherapy. So in my clinical practice, I tend to be very careful in trying to identify those that might have a higher proliferation. So we are fortunate because we work with a very good breast pathology group. So it's very easy for us to get on the phone and talk with a pathologist and get their opinion. And sometimes, even in the histologic grade, I'm going to talk about it more tomorrow. The histologic grade has 3 components, and one of them is the mitotic score. And a patient that has a high proliferation is expected to have a high mitotic score. So there are lots of small pieces that we try to put together to really not to miss anyone that might benefit from chemo.
One of the chemotherapy agents that are often used, and this question came up several times from the advocates, are the group called taxanes. And one of the observations about how lobular cancer looks when you look at it under the microscope is related to absence of tubule formation. Would that have an impact on the efficacy of taxanes?
So not really, because the lack of tubule formation in lobulars, it's a different, it's a morphologic appearance of lobular carcinoma, and it's different from the tubules that are inhibited by the chemotherapy, the class of chemotherapy called taxanes. So these are different concepts, and I'm very surprised that the advocates know about the lack of tubule formation in lobulars. You're really very well prepared, and it's
Definitely never want to underestimate the power of a patient who is advocating for him or herself. So the next question is, does ECAT hearing loss affect the behavior of primary and metastatic tumors? Does ECAT hearing loss affect the behavior of primary and metastatic tumors?
Well, I think that's fundamentally what makes lobular cancer different, and so I would say yes, and I think we've seen a lot of presentations to that effect today. I mean, I think that loss of cell-cell adhesion is perhaps what makes it spread in the manner that it does, and why we see unusual patterns of metastatic spread, and why we see different presentations with the primary tumor. I think that's the fundamental, one of the fundamental underlying mechanisms by which that occurs. I don't know if the basic science people want to chime in on that.
Yeah, I would just say that I think we saw a really nice keynote talk this morning from Dr. Patrick Dirksen, who really showed using various models that loss of ECAT makes the cells more metastatic, more migratory. So yeah, I thought that was quite nice. I'm not sure if he's still here. But... So the answer is yes.
So a very frightening thing in the life of a person who's diagnosed with breast cancer is to hear the words, you have breast cancer. But what's even more frightening is you have a recurrence or you have a progression. And so the question here is, are there risk factors for recurrence specific to ILC?
I don't think that we truly know the answer to that beyond normal risk factors for recurrence, such as, I mean, I think nodal status has always been one of the single most powerful predictors of recurrence. We've been talking a lot about oncotype and why lobular, I mean, oncotype, beyond predicting chemotherapy benefit, is also supposed to be a predictor of recurrence, but maybe we just haven't found the right predictor of recurrence for patients at risk for late recurrence, for instance, and maybe that's not the right test for that. But I think that's another area of work that we have to continue to work on. But I think right now we rely on more traditional risk factors such as stage and nodal status and response to systemic therapy. If you have the utility of seeing response to systemic therapy in real time, you know, where you're tracking tumor biopsies, I think that probably predicts risk of recurrence. And I think that now that we have this notion of increased risk of potentially late recurrence with lobular cancer, and now we have data to perhaps be continuing aromatase inhibitor therapy for up to 10 years, I think that for patients that can tolerate that on a quality of life basis, that may not be a bad idea for a lot of patients who are higher risk until we get better biomarkers of late recurrence.
Any other thoughts on that?
I guess from the bench perspective, I think I can comment that the perceived tamoxifen resistance that we've been talking about, the poor outcomes on tamoxifen, to those of us that study hormone receptor function, that kind of screams that there's some biological factor present in ILC cells that drives that resistance, that mediates that tamoxifen resistance. So one of the goals of those of us using model systems is to identify whatever protein is present that drives the resistance. So theoretically in the future, that would be the biomarker to predict poor outcome, which is why we use things like the resistant model systems.
So another theme that was very common in the questions posed by the advocates were novel strategies that are coming down the pike in the future. Are there any data or any studies looking at cancer stem cells for the treatment of lobular cancer?
There's certainly studies looking at cancer stem cells. I don't know of any looking specifically, at lobular cancers. Maybe more in general, and hopefully up. I do think in many of the talks today, we touched on a number of potential agents to be and are being evaluated in lobular cancers, including PI3 kinase inhibitors. Those are present in almost, its mutations are present in almost half of lobular cancers. The AKT pathway, which is upstream of the PI3 kinase, was identified in our keynote talk and in our TCGA work as being sort of a molecular target that looks active in a majority of the lobular cancers. Christine gave a great presentation highlighting the importance of potentially HER2 and HER3 mutations. There are certainly targeted agents to get at the HER2 mutations. We touched on immune cells in lobular cancers, some very exciting work going on with manipulations of the immune systems in other cancers that are now being evaluated in breast cancer. And then actually a class of agents no one talked about today, the CDK4/6 inhibitors, which are now gaining use and approval in ER-positive cancers in general. I don't know, maybe some of my clinical colleagues could comment on whether those have sort of been evaluated individually within lobular cancers, but I think that's also another promising class of drugs that are being tested, have been tested, have promise.
Question there.
Looked at restoring estrogen.
So I think restoring E-cadherin would have a couple of differences that are different than potentially getting ER to get back turned on, right? For example, the gene is mutated, right? And actually many of the mutations cause it to only make half the protein. So if you were able to sort of turn it on again, you'd turn on or it's already there, it's a dysfunctional protein, so that couldn't help. It kind of falls probably generically into the world of gene therapy, where you'd need to deliver the normal protein. Maybe you could CRISPR it back in. It still gets back to gene therapy, and can we deliver genes in a sustained fashion and then get sustained expression? And we haven't been able to do that, right? So if we could ever do that, we would profoundly impact cancer treatment, because we deliver all kinds of genes in that fashion. But unfortunately, we're not there yet. People are still working on it very hard, and I think that's an approach that, again, the payoff would be so big that we need to keep working on that.
Can I just quickly come back to the question of stem cells? I mean, given that there are more and more data showing there are many late recurrences in patients with ILC, we did think that the disease is a good example for a disease what we call dormant, or a lot of dormancy in this disease, where these cells hang out somewhere in the body and then suddenly, for one reason or another, after many, many years, suddenly start to wake up again. So, what people have shown is that, and sometimes in these dormant situations, that you have more stem cell-like properties of some of those tumor cells. So we looked at this a little bit just in model system, which is obviously each model system always has its limitation. And so far, we don't really have any evidence for that, although I think that is a very interesting question.
What about androgen receptor targeting?
So at least biochemically, there's actually a poster by Dr. Riggins' lab in the back. So from a model system perspective, we're certainly considering it. our model systems all tend to express androgen receptor, and we have every reason to think that biochemically they'll respond to it, whether that's a clinical agent. I mean, there are trials ongoing for novel agents like enzalutamide in ER-positive breast cancer, but they're not specifically accruing ILC, so I don't know that we'll know for lobular cancer until the main ductal-driven trials come in.
All of the trials we have for androgen receptor antagonists right now are in triple-negative disease. We don't have any open for ER-positive right now, but I think that that's of interest because they're already out there being used for other cancers for other reasons. So it's always nice to exploit a drug that is not expensive and really new if it's applicable now. So something.
I don't think in the TCGA there was extremely high expression of the androgen receptor in the lobular tumors, right? At least nothing higher than in the ductal cancers, right? There is?
I mean,
Yeah, no,
almost all ER-positive cancers are AR-positive.
Yes.
And I think that probably holds true in lobulars. Now, if it's a key point of driving tumors like ER is, I think that's what needs to be figured out. And
Yeah.
enzalutamide, the AR antagonist, there are some studies in ER-positive breast cancers. There'd probably be a few lobulars in there, but maybe not enough to get specifically at it.
Yeah, no, I think my point was whether there was specifically high expression in the primary tumors, or is the idea potentially it actually is expressed more in the metastatic lesion, is expression higher after knocking out ER?
That I don't know.
Becca, do you want to comment quickly?
Looks like there's a question back there. Couldn't have had better timing because the next question actually was related also to clinical trials specifically for patients with ILC. Is that becoming more common? Are trial designs more common specifically just for patients with lobular cancer? And what is the best way to advocate for adequate enrollment of patients with ILC on current and future trials?
Now, this is a great question, and the scientific community, until a few years ago, really felt that lobular was not so different to be studied separately in clinical trials. And in truth, we didn't have much hypothesis to do so. So lobular is a disease that's estrogen receptor positive disease. And we're going to see from the data from the big 198 that does behave quite similar to estrogen receptor positive in general. But we know that there are all these differences. We always have discussions about lobular carcinoma in our tumor boards when we're discussing cases in our daily practice. And we know that's different. Now we're getting into a point where we're starting to have hypotheses that can be tested in clinical trials. And we have just a few clinical trials that are dedicated to lobular carcinoma open as of today. I have one that's called PELOPS that treats patients with pre-op endocrine therapy plus or minus palbociclib, which is one of the new CDK4/6 inhibitors. Rachel has a trial, which is a window trial with 3 modalities of endocrine therapy given before surgery. We learned that there are new studies coming up in Europe for patients with advanced disease. I was just discussing with a colleague saying that we should try and consider discussing about clinical trial designs for patients with metastatic lobular carcinoma here, so our patients would have access. So the field is evolving quite fast, and I think that we're going to learn more and more. And I think that going straight into your question, how the patient advocates can help, you can help making the trials happen, making the trials visible, talking to patients, and because you are the real importance or the real force behind our motivation to make these things better.
Yeah, I would second that both of our trials are for patients with newly diagnosed cancer. And that isn't and both of them are going to rely on more than one site to recruit patients. And that's a stressful time when patients are just newly diagnosed. And so to get them to do a clinical trial at that point when they're going through the trauma of just having found out that they have cancer can be a challenge. So anything we can do to tell patients these trials are out there, they're at, where the sites are and how they can get access to them would be extremely helpful.
Maybe
I would
can
just
say
add
something.
go
ahead, Grace.
One other way that advocates can help is convincing newly diagnosed patients that they do not have to be in the operating room in a week, that systemic therapy is active treatment. It's treating not only the whole system, but it's also treating the tumor in the lymph nodes. And treating prior to surgery is the best opportunity to study how well our therapies are working. After that, there's no way to measure. It's just a crystal ball, whether it's coming back or not at this point in time. And the point of entry for most breast cancer patients is the surgeon's office, and very often they come in with this notion that they're going to be in the operating room, and it's sometimes very hard to convince them to go on a trial where they may be on endocrine therapy or chemotherapy for a period of time. But if they have a savvy group of breast cancer survivors living with or without breast cancer, it would go a long way to educate newly diagnosed patients.
Just want to add something from the research point. In all honesty, sometimes in the lab you do, and maybe that's human nature, what's easy. When we found some evidence for specific pathways being activated in lobular cancer a few years ago, that's when we started to research lobular cancer. I wrote my first NIH grant about ILC, and I proposed to use 2 estrogen receptor positive ILC cell lines, because that's the only thing what was out there, in contrast to like 50 ductal cancer cell lines. And the grant got rejected, saying you have to be kidding me to try to use 2 cell lines as a representation of ILC. And it's true, but that's the only thing what was out there. So I think at this point you either go the easy way and say, okay, well, let me take those 50 ductal cancer cell lines and look at the pathway, or you sometimes, I think you need to go new ways and then say, okay, well, let's try to generate some, or, like what's on this question, get people together and collaborate, and let's see if anybody else made some somewhere in the world and collaborate. So I think in the research side, sometimes, it isn't easy, and maybe we try to go the easy way, and I think there weren't any models out there for ILC in the last 20 years. So I think that really changed over the last few years, over the last 2 or 3 years.
And I would follow up on Dr. Arndt's point related to clinical trials. As a member of the Breast Cancer Research Advocacy Network at Pitt, one of the things that we have done is actually gone out to survivor groups to talk to them about clinical trials, and there is often a misconception that a clinical trial is what happens when there's nothing else in standard treatment left. And so I think one of the really important roles of an advocate is to help fix that misconception for people to understand that that's not the only use of a clinical trial.
I mean, I think that's not specific only for lobular cancer. I think in general, research totally relies on access to clinical specimens. And just based on the fact that lobular is only 10%, 10 to 15%, clearly we have even fewer specimens. I think now with the TCGA, and with many other studies, I think we have a pretty good understanding of the primary disease. I think what the biggest holes are now is first access to metastatic tissue. And second, for the primary disease, we have a lot of access to frozen specimens or specimens in paraffin. What we really try is to get access to fresh specimens that we can then immediately grow in the lab. So there are still lots of holes and lots of bottlenecks which clearly limit research.
Purpose here have met for us for getting us involved in clinical trials. Be a part of a clinical trial right now because we don't have Andy Anderson yesterday. I want you to have a good old tumor.
I think that we should have a task force as a result of this meeting with action items, and that should be one of the leading ones to try to address that particular question.
And a follow-up to that is questions posed by the advocates related to what is being done between institutions and between different universities and industry to pool data, to pool tissue, to pool other resources to speed the progress of ILC research.
I can address that. It's actually a very active area at the moment. Traditionally, breast cancer has been one of the most collaborative areas. It had something called the Early Breast Cancer Trialist Group, which pulled together all the clinical trials data, and that's like the gold standard now for understanding clinical outcomes in breast cancer. There's now, I don't know if many of you saw it, but Joe Biden, when he announced the Cancer Moonshot Project, the first thing he talked about was the inability of sharing data between institutions. A lot of that is to do with institutional regulations, unfortunately, but he's really put a push on that. There are now 8 national projects of data sharing. ASCO has one called Cancer Link, and AACR has one called Genie. Joe Biden was a little bit upset that all of these people were doing their own things with their own programs, but those are going to be pretty impressive. So AACR Genie now has 8 institutions, which next month will release, very soon will release data on 20,000 individuals, their clinical data and then their genetic sequencing data. And so it's only through that you're going to then, with these large numbers, then you'll learn about ILC being a small subset of cancers. Like with TCGA, when you get to these large numbers, then ILC suddenly now will have enough in there. And so I think there's a big push to share. I think pharma is very vested in this because obviously as we get to smaller and smaller groups of patients, so say for instance your mutation is only in 2% of patients, well they need a lot of patients to try and find that. So they're vested in finding it. Obviously academia is invested in understanding it. So I think these groups, within the next 2 to 3 years, you'll see these large public resources of data that's going to be very useful for subtypes like ILC.
So we have about 5 minutes left, and so I wanted to ask the 25 advocates who put in questions, was your question covered here today? And if not, please ask it now. Sure.
Yeah, we don't have any data to point us into this direction. And the study that I said that we have with CDK4/6 with palbociclib, this study also answers a question of tamoxifen versus letrozole, lobular and ductal, and considering these are all ER-positive diseases with palbociclib in combination with letrozole. We don't have any data in the metastatic setting pointing that CDK4/6 inhibitors should work better or worse in lobular, and they're expected to work pretty well. So in that advanced disease, the lobular carcinoma is different. The disease changes over time, and we're going to talk a little bit about it during my presentation tomorrow. And I'm going to show data where the benefit of chemotherapy for lobular compared to ductal for patients that have had multiple lines of chemotherapy seems to be very similar. So what we have to bear in mind is that once we give treatments, the disease changes, and when we think about the disease in early stage, it's different from metastatic, and it's different from metastatic that have been treated with previous lines of treatment.
Brown shirt had a question.
First of all, I want to thank you all for your time. You've all been more. I don't normally see doctors.
You should come here.
I work with a doctor who does clinical studies. And I'll tell you the best thing, and it just dawned on me now, what we should have done, we should have had a reporter here writing about this symposium and about lobular cancer. My daughter has it. I still did not know that much about lobular cancer. So I think all the advocates for go back and get on social media, get a local reporter from their have them write an article about this. From a different country, need to get one of your patients or your hospitals or something. Also write about not only the symposium, but what all you are doing for lobular cancer, because most of the women who get cancer are going to think it's regular breast cancer, and they have to go get chemotherapy with an IV and vomit for months and months and months. They're not going to realize that this is a different type of cancer and a different type of medication that you need to fight. I think y'all should get out there and publicize.
So I wanted to remind everyone that tomorrow morning from 7 to 8 is the Hot Topic breakfast. And several of our panelists here are actually going to be back tomorrow morning. And remember, we're in the Cooper classroom tomorrow across the street. But they will be there. They will be identified by their sign, radiology, medical oncology, basic science, Libra, Taurus. And so they will be there to answer more questions as well. But it looks like we're probably going to need to go ahead and wrap up now, but we can continue these conversations tomorrow. So thank you so much for attending.
You and me. I'm going to send it to Lisa.